Hi everyone, today I'm presenting the research project on antiretroviral therapy and COVID-19 outcomes in HIV-positive men, using dataset from Veterans Aging Cohort Study. So the ongoing COVID-19 pandemic has led to over 200 million cases and 5 million deaths worldwide, and there is no antiviral drugs developed against SARS-CoV-2. So what about repurposing antivirals that existed before the pandemic? For example, remdesivir, a drug that's originally developed for hepatitis C and Ebola, has shown to speed up the recovery time from COVID-19 slightly by randomized trials. It was approved by FDA in the US last year. It's an IV drug and it's quite expensive. It costs more than $2,000 per treatment course. Molnupiravir is a drug that's originally developed for influenza. According to randomized trials, it estimated around 50% risk reduction for COVID-19 hospitalization or death. It was actually just approved in the UK yesterday. This is a screenshot of the news. It's an oral drug, but it's still expensive. It costs about $700 per treatment course. Another example is tenofovir. It is a drug that's originally developed for HIV. It's an oral and expensive generic drug, but it has not been studied in randomized trials yet, maybe because it's not lucrative enough. Let's take a closer look at tenofovir. There are two forms of tenofovir. Tenofovir disoproxil, TDF, and tenofovir alafenamide, TAF. They both may interfere with the SARS-CoV-2 RNA polymerase, but TDF reaches higher concentrations in most tissues compared to TAF, implying that TDF might be more effective against SARS-CoV-2 compared with TAF. So currently, TDF is effective for treatment and prophylaxis of HIV infection, together with emtricitabine as FTC. It's also used for treatment for chronic hepatitis B infection. TDF is shown to be safe even in pregnancy. It's possible to cause renal impairment after prolonged use, but it's rare and fully reversible after discontinuation. There are several observational studies looking at TDF use on COVID-19 outcomes. Among individuals with HIV infection, there are two studies in Spain and South Africa. They both found a lower risk of COVID-19 related events for individuals treated with TDF-FTC compared with other antiretroviral regimes. Among individuals with chronic hepatitis B infection, they found lower risk of severe COVID-19 in individuals on TDF versus entecavir. One potential problem with observational studies is confounding. So let's take a look at this screenshot of the results from the Spanish study based on HIV-positive individuals. In this table, we are seeing the risk estimates per 10,000 individuals. And in the last section, we can see people receiving TDF-FTC had a lower risk of COVID-19 diagnosis and COVID-19 hospital admission compared with other regimes. These are risks without adjusting for any confounding. So one explanation could be that the lower risk of COVID-19 events that we observed are because that people taking TDF are different from the others, not because TDF reduces risk. So specifically, we're talking about confounding by comorbidities, especially for chronic kidney disease, because individuals with chronic kidney disease are less likely to be offered TDF because of potential concern of renal toxicity. So we need observational study with proper adjustment for confounding, especially by comorbidity. And that's exactly what we're trying to do here. The data we used is from Veterans Aging Cohort Study, VAX. It includes US veterans currently in care at 9 VA medical centers. Among this population, the HIV-positive cohort is predominantly male. This is also the cohort that we're using. And the medical records include detailed data on comorbidities, which allows us to control for confounding better. The goal of this study is to estimate the effect of TDF on COVID-19 outcomes, and to do so, we compare the adjusted risk of COVID-19 outcomes among HIV-positive male veterans by antiretroviral therapy. We will be calling it ART regime throughout this presentation. We categorize the ART regime into 4 categories: TDF-FTC, TAF-FTC, ABC-3TC, and other regime. We included individuals who are HIV-positive, male, over 18 years old on ART, whose CD4 cell count and HIV viral load were measured in previous 12 months, who had adequate virological control, defined as HIV viral load below 200 copies per milliliter in previous 12 months, and who were never severely immunosuppressed, defined as no history of CD4 cell count ever below 50 cells per microliter. Also, people without previously documented COVID-19 diagnosis. We specify that their baseline month should be on or after February 2020 is because the first non-travel related cases in the US were identified towards the end of February 2020. Here's the flowchart, and we can see out of 31,302 HIV-positive individuals in VAX, we ended up selecting 20,117 individuals eligible for this study. Among them, about 61% were on TAF-FTC, only 4% were on TDF-FTC, around 18% were on ABC-3TC, and the rest of them were on other regime. The mean age of this population is 59 years. The baseline characteristics were similar across groups, except that the prevalence for chronic kidney disease was 4.3% in TDF-FTC, 7.7% in TAF-FTC, and around 14% in ABC-3TC and other groups. So we see the prevalence is much lower in TDF-FTC and slightly lower in TAF-FTC. As we mentioned before, it might be because the physicians are less likely to give TDF or TAF to people with chronic kidney disease because of potential concern of renal toxicity. Additionally, individuals in other regime were slightly older, had lower CD4 count, higher viral load, and higher percent of comorbidities. We estimated the 12-month risk of the following outcomes, including documented SARS-CoV-2 infection, which is confirmed by PCR, COVID-19 related hospitalization, ICU admission, and death. These 3 COVID-19 related events were defined as events that happened within 30 days of a positive PCR test. These risks were standardized by the following baseline covariates, including basic demographics, HIV lab values, clinical measurements, calendar month, hospitalization in previous month, and comorbidities, including chronic kidney disease that we kept talking about. So these are the standardized survival curves that we obtained. Notice that the last 2 curves, the scales are zoomed in compared to the top 2 graphs because we obtained fewer cases in ICU admission and death. So in all 4 graphs, we can see people taking TDF and FTC, represented by the green dashed line. They had better survival compared with other regimes across all 4 COVID-related outcomes. And here are the risk ratio estimates along with their 95% confidence interval. Here we're using TAF-FTC group as the reference group. And again, we can see that people receiving TDF-FTC had a lower risk compared with other regimes across these 3 outcomes. Here we're not showing outcomes for COVID-19 death because there were no COVID-19 death observed in the TDF-FTC group. So the risk ratio for that specific group is just 0. We also conducted a list of sensitivity analyses, and we obtained similar estimates when we used hazard ratios rather than risk ratios. when the follow-up ended on December 31st, 2020, which is about the time when the COVID-19 vaccination campaign was launched. Also similar estimates when we included both females and males in this study. So just to summarize, in this study, we found that the risk of severe COVID-19 was lower for HIV-positive individuals on TDF-FTC regime compared with other ART regime. And confounding by comorbidities does not appear to be the explanation. This finding is consistent with previous observational studies. And randomized trials are needed to estimate the effect of TDF in HIV-negative individuals for pre-exposure prophylaxis and for treatment of SARS-CoV-2 infection. Lastly, I would like to acknowledge the contribution of a few collaborators listed here from VAX and CAUSALab and from the funding support listed here. Thank you.
Thank you, Katherine. Any question from the audience?
I may have missed it, but when did the baseline start? Was it at the moment of treatment initiation, or did you look at treatment? And what kind of implications does it have?
Yeah, so we listed a bunch of eligibility criteria, and we're looking for baseline that satisfy those criteria. For example, they have their HIV viral load and CD4 count measured within the, I'm sure that's that helps. So we're looking for all those eligibility criteria, and we use these to define the baseline month. And we need to specify the baseline month should be on or after February 2020. And it's not the time when their treatment was initiated, because based on these metrics, they should have been on the ART regime for long enough so that their HIV viral load is under well control. Is that answered?
And what did you do if patients would be eligible at multiple months or days? Did you choose the first moment of eligibility?
Yes, so if they are eligible for more than 1 month, then we would choose the first eligible month that's on or after February 2020. For example, if they're eligible in January and February and March, we would select February 2020 as a baseline.
I'm sorry, so could you just help me again with what the time zero is here? And you haven't mentioned ART therapy prior to time zero, and whether that was taken into consideration.
Yeah, that's a great question. So time zero here would technically be the time when they initiated the ART treatment, and we don't have that information available here. So here we started follow-up since the baseline month, and they only have the possibility of getting the COVID-19 disease since February 2020. As I explained, that's the first month when the non-travel related cases were identified in the US. So it's like a trial where we randomized people to different regimes a long time ago when they initiated the ART regime, and then we just don't care about the first half of follow-up period, and we started following them up from a specific time point, which is their baseline month in this study. Does that make sense?
Thank you for the question. Food for thought. Yeah. Any more questions? Here we have a couple of questions in the chat. And one question is whether you think your findings could explain why the observation that people living with HIV had lower risk of COVID or severe COVID-19, and that in some countries where HIV is very prevalent and many people are being treated with these medications, that we are observing a lower identified risk of COVID-19 as well. So do you think that being treated is protecting some of the people living with HIV?
So here we're not comparing people with and without HIV, but we're comparing different ART regime among people with HIV. So I guess we cannot draw any conclusion about having HIV versus not having HIV. What would their COVID risk be?
Yeah, I think that the comment was that in populations that are being treated with tenofovir specifically, like for PrEP, or if that has been protecting them from having COVID or severe COVID-19, so it's more of an observation.
Yeah, that's a good question, and I think that would need another study to answer that question. And also, I think there would be more confounding in that setting. So we would have to fully control all confounding and analyze that.
Actually, a related question to that is whether you think that your findings of the protective effect of tenofovir in these populations that you use that had HIV can be generalized to populations without HIV, so that if we can use the treatment to prevent COVID, if the patients or people don't have HIV.
Yeah, I guess that's one of the limitations of this study. I don't think it's generalizable to individuals without HIV. So that's why I mentioned here that we would be randomized trials to conduct, to explore the effect of TDF on COVID-19 outcomes among HIV-negative individuals.
But why would it not protect from COVID individuals without HIV?
I think HIV-positive and HIV-negative individuals, there are some literature suggesting that they have there might be some association between HIV infection status and COVID-19 outcomes. They didn't say it's causal, but there could be some associations like their immunosuppression status and also the ART that they're taking. So I think it's a very complicated question, and I do not want to draw the conclusion that I want to generalize this result to HIV-negative individuals.
No, so you want to test it. Any other questions from the audience? I have one question, if I may, that because you started to answer that to Dr. Walker, and how would you emulate the corresponding hypothetical target trial for the same question? If you were to conduct a real randomized trial, corresponds to your emulation.
It's an interesting question. So you're saying emulating the trial that we will conduct in HIV-negative?
No, like, yes, what would be the underlying target trial for this study?
For this study?
Yeah, for this.
Yeah, so I guess we would randomize HIV-positive individuals at some point into different ART regimes, and then we follow them up long enough so that their HIV infectious status is very stable. Like they have viral load under detection, and they have a stable CD4 count. And then we started following them up at some point, and we exposed them to SARS-CoV-2 virus. It's unethical, but it's a hypothetical trial that's kind of equivalent to this observational study that we're conducting.
Any final question? If not, thank you again, and congratulations for your work. Let me